Thank you. Good morning, everyone, and welcome to this morning's webinar hosted by Action on Smoking and Health and the Smoking in Pregnancy Challenge Group. I'm delighted to see so many of you here. I keep seeing the names popping up coming in as I speak. My name's Lee-Davey. I'm the Chief Executive of Bliss. We're the UK's leading charity for babies born premature or sick. We provide comprehensive information and support for parents with a baby in neonatal care. We work with health professionals to improve the quality of care. We do policy and campaigning work to secure national change, and we support research to improve tangible outcomes for babies in neonatal care. And it's in this capacity that we've been delighted to support the research programme, which has informed the development of the Love My Lungs intervention, which will be showcased this morning, which has been designed to support families of babies born premature or sick to maintain smoke-free homes. So as you'll see through the session, the Love My Lungs intervention is a really practical package to equip healthcare professionals with the confidence and the tools that they need to engage parents in a really supportive way to maintain smoke-free homes, which we know is best for babies and best for families. Now, we've got over 300 people registered for today's event, and I think we've got over 100 at least already in the room. So you're all very welcome, including, I know we've got some parents joining us today, and you are particularly welcome to join us. That's lots of people and a very busy agenda. So we do have a few pieces of housekeeping before we start. The meeting is being recorded, as you'll have seen, and that recording and the slides will be circulated to all attendees and uploaded to the ASH website after the event. Please can all attendees and panellists keep themselves muted and turn your videos off unless you're presenters. ASH staff will make sure that everyone is muted who needs to be, just to make sure that we can all hear the presenters nice and clearly. And we encourage everyone to use the chat. Please do submit questions and reflections throughout the session, and we will discuss those, particularly the questions, during the Q&A sessions. We particularly encourage any parents attending to share their reflections and experiences, and we will try to answer as many of those questions that are posed in the chat at the end as we can. And if you have any other issues during the event, please put that in the chat or email admin@smokefreeaction.org.uk, and a member of the ASH team will try and help you out. So as I said, we do have a very busy agenda today. There is only one slight change to the agenda. Unfortunately, Amy Nichols, who was due to be giving us the NICU nurse perspective, unfortunately she has COVID, poor thing. So I'm sure we all wish her well, but obviously that means she's not able to present in her session. I believe she may have said she's joining the event anyway and watching, and may dabble in the chat. I would encourage her to look after herself, but what that means is we'll skip that slot and have a little bit more time for questions and discussion at the end. So without further ado, I'd like to introduce our first speaker, who is Professor Caitlin Notley, who's the Chair of Addiction Sciences at the University of East Anglia. Caitlin is leading on the development of the Love My Lungs intervention, and she's going to start by updating us on the evidence base for this work. So Caitlin, over to you.
Thank you so much, Caroline, for that introduction. I'm really delighted to be here this morning to welcome you all and talk to you about the background evidence underpinning the Love My Lungs intervention. We're extremely excited as a team to be able to start to showcase the intervention, and I'm sure you're all keen to have a bit of a look at it as well. But we'll start by just talking a little bit about the background to the evidence of what we know about tobacco smoking, particularly in relation to families of babies admitted to NICU. So I have, thank you. So just starting with tobacco smoking in the UK, what we know about who remains regular smokers in our population. Well, this is latest data from the Smoking Toolkit study, which is a national survey conducted every month of the general population. This shows that we've seen smoking prevalence in the UK fall year on year, which is obviously extremely positive, currently sitting at just less than 15% of the general population remain regular daily tobacco smokers. Next slide, thanks. But there are marked health inequalities in the level of smoking prevalence in the UK. So we know actually that for women of childbearing age, they're much more likely to be smokers than other members of the population. So about 1 in 5 women of childbearing age are currently regularly smoking tobacco. And there's huge health disparities. So people from routine and manual occupations or people who are unemployed are much more likely to be regular tobacco smokers than those in the higher managerial and professional occupations. Looking specifically at families of NICU babies, we know that those earning in the lower earnings bracket, and this is data from the States, but equally applies to the US, families much less likely to have a total smoking ban in place in the family home than families who are earning in the higher wage bracket. So there's a correlation there between tobacco smoking and other health inequalities and disparities. Next slide, thanks. So specifically focusing on families of babies who've had a baby admitted to neonatal intensive care, it's quite difficult for us to ever to estimate the exact prevalence of tobacco smoking. One big issue is that the patient on the neonatal unit is the baby. So often parents are not asked at all about their smoking behaviour. Sometimes it can be quite obvious to the staff working on the unit, but it's quite hard for us to estimate the exact prevalence. So in development work that we undertook a couple of years ago now, we asked all parents admitted to the neonatal unit in our local hospital in Norwich about their smoking prevalence. And we found that around a third of parents, so this is mums and dads, told us that they were actively smoking tobacco at the time of the baby's admission. Approximately a third of parents told us that they were ex-smokers, so they had quit either for the pregnancy or sometime during the pregnancy, therefore potentially at a high risk of relapse. And a third of parents told us that they had never been tobacco smokers, although they felt that smoking could still be an issue for them, for example, family members or visitors coming into the family home. Next slide, thanks. So thinking about some of the impacts of tobacco smoke exposure on the most vulnerable infants, those admitted to neonatal intensive care. Well, we do know from evidence from the United States that tobacco smoking particles are present in neonatal intensive care units. Despite it being an incredibly sterile and clean environment, smoking particles have been found on NICU furniture and on incubators from swabs that have been taken. So this suggests that somehow there is exposure to tobacco particles that are being brought into the unit. Smoking chemicals have also been found in the urine of NICU babies of parents who smoke. And interestingly, this includes parents who are not breastfeeding but formula feeding their babies. So it suggests that tobacco smoking particles can be passed on to vulnerable infants, not just through the breast milk of a mum who continues to smoke, but through other means, perhaps through skin-to-skin contact or where particles remain on the skin and clothes and hair of the parents. We know, sadly, that babies of parents who continue to smoke are likely to stay longer on the neonatal intensive care unit. Obviously, huge cost to the healthcare system of providing that intensive care, but also huge social and emotional cost to the families during the time of the admission. And interestingly, really, new emergent research from Norfolk in the United States is suggesting that NICU babies who've had greater exposure to smoking particles throughout pregnancy and then immediately post-birth have a less diverse microbiome. So there seems to be possibly some other interactive effects of exposure to tobacco particles that could have other health concerns and complications for these most vulnerable infants. Next slide, thanks. So we know that babies born to mums who have smoked throughout pregnancy weigh on average 200 grams less than those born to mums who are non-smokers or able to quit smoking. Of course, being of low birth weight is a key reason that a baby may need admission to a neonatal intensive care unit for that extra level of care. So babies born to mums of smokers are 40% higher risk of being born preterm or very preterm. We know for these infants that lung development is incomplete as well as other organ systems, but particularly the lungs. And many babies, because of this, need very significant medical intervention and protracted respiratory support. These infants are particularly vulnerable to infection, and both immediately post-birth and during the admission, but also following transmission home after the admission to the unit. Secondhand smoke exposure in the home for families where who continue to smoke, for babies generally, as well as preterm or unwell babies, increases the risk of sudden infant death syndrome, suffering from respiratory conditions, infections such as ear infections. And these risks are particularly high for babies who've had a NICU admission where they're extremely vulnerable in the first place. So there's an additive effect and danger of exposure to tobacco particles. And then also, really importantly, there's a prevention aspect to supporting parents during the time of the NICU admission. So avoiding exposure to second-hand smoke is not only beneficial for the vulnerable infant, but also other family members. And then thinking about this infant and other children in the home growing up, we know that children of smokers are 4 times more likely to go on and become regular tobacco smokers themselves later in life. So if we can halt that transmission of smoking behaviour, we can help to prevent future ill health of family members as well. Thanks. Next slide. So why don't parents just stop smoking? You'll have to click through the images for me, please. Well, we know that addiction to tobacco smoking is one of the most powerful addictions. It's the nicotine within the tobacco that's the addictive substance, not necessarily the substance that causes the harm to health. It's the other components of tobacco smoking and the toxicants contained within tobacco smoke that cause the most health risk. But it's the nicotine addiction which is so difficult to overcome. Many smokers try and fail to quit many times, and most smokers, if asked, will actually tell you that they want to quit smoking, but they just don't know how, or they've tried and failed and perhaps given up trying because they don't know how best to do it. The NICU admission, of course, is incredibly stressful for families, even families where mum and dad have perhaps managed to quit smoking during the pregnancy, potentially especially vulnerable to relapse back to tobacco smoking during the time of the baby's admission, just because of the huge stress that's put on them at that time. And we know that stress is one of the major predictors of smoking relapse in pregnant women who've managed to quit smoking during pregnancy. So having a baby admitted to NICU may be a particularly important time where we have an opportunity to intervene. And then thinking about the behavioural mechanisms underpinning quitting smoking. So the combi model of health behaviour change is something we refer to in our intervention. We look at the capability of parents to be able to quit. So many parents may not feel capable or equipped with the tools to be able to successfully quit smoking. Perhaps they're not motivated to quit smoking. They may not fully understand the health risks for themselves or their baby and don't have the motivation at this time to quit smoking. And many parents tell us they don't have the opportunity to be supported to quit smoking. So they haven't been offered support, or they haven't been offered perhaps pharmacotherapy to help them with their nicotine addiction. So addressing those elements of behaviour may be something that's particularly important for us, thinking about how we can support parents. Thank you. Next slide. Okay, so what might help? Well, we know that stopping smoking or staying smoke-free for those parents who have been able to stop is one of the few things that parents can really do during the time of admission to neonatal intensive care to really improve the longer-term recovery and health of their offspring. Aside from breastfeeding, staying smoke-free is probably the key thing that parents are actually able to do to change the outcomes for their baby. And parents often feel very vulnerable at this particular time, very helpless, unable to do anything. But stopping smoking is something that parents can really do that might change the outcomes for their child. There's really good support for healthcare professionals on NICU now through the policy. We have the NHS long-term plan and NICE guidance now recommending smoking cessation and support for all patients and carers at every point of contact with secondary care. And the recent CAN review, the Independent Tobacco Review, is really focused on supporting mums to stop smoking at all stages throughout the pregnancy pathway. But NICUs have really been missed out of that and are really a sort of special case for consideration, hence the need for us to develop something particularly targeted at families in this very particular environment. So the NICU admission for parents may present what we call a teachable moment, a really key time in parents' lives where they're extremely stressed, but really possibly open to health behaviour change because they want to do, of course, everything they possibly can to support the health of their baby. At the moment, though, there's no UK intervention and no recommended support for healthcare professionals to deliver while the baby is admitted to the neonatal unit. So there's been some trials in the US. We know that there have been some positive findings. Norfolk et al. Particularly have looked at nicotine replacement therapy combined with behavioural advice and found some success with that. And another big trial looked at the use of incentives for women to quit smoking combined with nicotine replacement therapy, and also found that that might be a particularly successful approach. But we haven't had any UK trials, so conclusions of the work in the US suggest that more robust interventions are needed. Those interventions need to include both maternal and critically partner or household smoking cessation as well. And of course, we need UK evidence too. Thanks. Next slide. So in our background development work, we were funded by the National Institute for Health Research to undertake a programme of work. We undertook and published a systematic review with looking at which particular components of interventions might be most useful for us to include within an intervention specifically targeted at NICU families. We undertook a whole programme of qualitative research interviewing mums, dads and carers of NICU babies during the time of the admission, and also focus groups with healthcare professionals working with parents on the neonatal units. And this work was all undertaken over the COVID lockdowns, so incredibly difficult study, but we were fantastically lucky that we were able to recruit the parents that we did, who so candidly shared their views with us to help us develop this package of support. So we started to develop the intervention, and then the final phase was testing the intervention out through person-centred interviews, where we spoke individually with mums and dads to test out aspects of the intervention and get feedback on further development. Next slide. So just the headline findings from our development work before we move on and speak to a parent who's joining us today. We heard that the intervention, and we found through our systematic review, needs to really be theory driven. So particularly effective interventions for behaviour change need to target those elements of behaviour which are most likely to affect change. Things like goal setting, social support and problem solving, for example. An intervention crucially needs to target mums, dads, and also the wider family, because we know that quitting smoking is so difficult if done in isolation. We heard through our qualitative work that parents really want to be asked about smoking. They do expect to be asked. Most want to quit smoking and would do so if they were offered support. And that support, parents told us, needed to be immediate. They needed support during the time of the NICU admission. It's not adequate to offer people a referral out to a community-based stop smoking service, which isn't realistic for parents to attend. Parents wanted that support to be immediate during the time when they were really struggling with nicotine cravings. Parents also told us that they wanted to know the hard facts about the health impact of tobacco smoke exposure on their preterm or unwell baby. They wanted to know the truth, just like we do with breastfeeding. They wanted us to be really clear about the impact that tobacco smoking might have on their baby. They also told us that they really wanted to hear information on third-hand smoke exposure. So what might be the risks of exposure to tobacco particles that might be passed on to the baby, for example, from the skin or hair of parents. Parents needed this information to be available to them in really easy to access ways, particularly digital intervention. Parents often use on their mobile phones for quite a long time on the unit, moving away from the old kind of information giving via leaflets. And this was particularly apparent during the time of COVID, obviously, when the units were completely paper-free. So parents also told us they wanted to have support with using alternatives. So it would be really helpful to be able to offer nicotine replacement therapy to parents during the NICU stay, or to give information and advice on using e-cigarettes as an alternative to harmful tobacco. Our healthcare professionals told us They really wanted to be able to have these conversations with parents, but they needed bespoke training to enable them to have those conversations in a way that wouldn't compromise the important relationship that they develop with parents who often on the unit for many weeks or months. And the brief intervention needed to be offered in a way that would avoid the stigma and shame that parents often felt around their smoking behaviour. So that's it from me. I'll hand back to you, Caroline, I think. Thank you.
Thank you so much, Caitlin. That gives us a really excellent grounding in the evidence. And as Caitlin mentioned there, the research has been really valuably informed by the insights and input from parents, most importantly. And we're delighted that we've got 2 parent speakers today. So first off, I'd like to invite Hannah Jones to take herself off mute, turn your camera on. Hannah had her own experience as a mum with a baby in neonatal care and is going to talk with Caitlin about that experience. So Caitlin and Hannah, over to you. Thank you so much for being here, Hannah.
Hi, Hannah. Yeah, thank you so much for being here. We really appreciate it. It's so important that we hear from parents throughout all the work we've done. So would you like to just start off perhaps by just telling us a little bit about your experience of having had a baby admitted to a neonatal intensive care unit?
Okay, thank you, Caitlin. Can you hear me?
We can hear you, yeah.
Yeah, thank you for this opportunity. I was a smoker while I was pregnant. I didn't stop and had my child at 30 weeks. And she was underdeveloped, so she had to go to the NICU. And it was really hard. It was one of the toughest moments in my life. So yeah.
Okay, thank you for sharing that, Hannah, and your story resonates with other parents we've spoken to who say that the NICU admission, you know, has been the toughest thing that they've ever had to face. Extremely traumatic, obviously, for you. And thank you for candidly sharing that you had been a tobacco smoker, but you did manage to quit smoking. And so was that during the time of the admission to NICU?
Yeah, that was during the time of the admission.
So could you tell us a bit about that? What made you decide to quit and how was it for you?
Well, I decided to quit because I wanted the best for my daughter. Yeah, and I felt guilty because somehow it was my fault she was there. Yeah, and yeah, what was the next question, please?
So, I mean, how did you find that? Were you offered any support with stopping smoking?
Yeah, like I had support from friends and family only. I wanted to be there, so outside support wasn't an option for me. Yeah, I didn't like the idea of getting help from outside, so I had help from my family and friends. Yeah.
Were you offered any support at all on the unit from healthcare professionals?
No support at all.
No. Okay. And would it have been useful to you to help you with quitting, do you think, if you'd been offered that support while your daughter was admitted to the unit?
Yeah, it would have been very, very, very helpful. Yeah, and I think sometimes it would have taken me less time to quit than it did. So yeah.
Thank you. That's really important for us to hear. And when you stopped smoking, did you have any other support? Did you use nicotine replacement or anything like that to help you with overcoming the nicotine addiction?
I used nicotine patches to help with the cravings. Yeah.
And was that something that you found helpful? Because obviously it's incredibly difficult, those cravings. It must have been, particularly while you were with your daughter on the unit, that must have been really horrible for you to deal with.
Yeah, they didn't work at first. I found myself smoking sometimes, but I developed self-discipline too, and yeah, so it was hard, but they worked in the end. So yeah.
Okay. Well, thank you so much. Really, really appreciate you taking the time to join us today, Hannah. And it's really important to have heard your story and really powerful. So thank you so much.
And we're now going to hear from someone else who spends a lot of time on a neonatal unit, Professor Paul Clarke, who's a neonatal consultant on the unit at Norfolk and Norwich University Hospitals NHS Foundation Trust, also an honorary professor at the University of East Anglia. And Paul is going to be talking again to Caitlin about the importance of supporting parents of babies on the unit to quit smoking from his perspective. So Paul and Caitlin, over to you.
Thank you, Caroline.
Thanks, Caroline. Paul, could you start just telling us a bit about your role, please?
Yeah, sure. Thank you for inviting me. It's a pleasure to be at this meeting. So essentially, I'm a doctor who looks after babies. That's my specialism within paediatrics. My official title is consultant neonatologist, and we spend the majority of our time looking after premature babies on the neonatal unit, but also sick term babies as well.
Thank you. And it'd be really useful to hear from you, Paul, from a clinical perspective, what the particular risks are for premature or unwell babies of exposure to tobacco smoke particles.
Yeah, so I think that the risks to them, they start well before the time of birth and the time we first meet the babies. So for a proportion of babies, their delivery has arisen prematurely because of problems related to the smoking, which can sometimes cause poor placental perfusion and poor growth in the fetus. So we're not infrequently faced with growth restricted babies who have their own particular needs, in addition to prematurity as well. So following delivery, further down the line, when they go home, they are at increased risk, we know, of upper and lower respiratory tract infections. The risks of asthma are increased. And the risk of cot death is increased for both term and preterm babies, but significantly more so for premature babies. And also a particular group of babies are those that are born the most premature, who develop something called chronic lung disease of prematurity. So the treatments we use to keep these babies alive, the ventilation we give them, although they're life-saving in the immediate term, those ventilation strategies can lead to damage to the fragile lungs. And those babies will have a degree of inflammation and scarring of the lungs, which they carry throughout their time on a neonatal unit. And some of the worst cases need to actually go home in oxygen. And these babies are really vulnerable, especially to tobacco smoke.
Okay, thank you. That's really useful to hear. And we've heard that we think smoking prevalence may be particularly high for families who've had a baby admitted to a neonatal unit. What do you think are the particular difficulties and challenges that parents face in quitting smoking during this time?
Yes, so the prevalence is something which we found difficult to get a handle on. You've already mentioned some of our prior work that we did together, trying to get a handle on that, because we're often dealing with outdated information and relying on what was collected at the time of booking when we're referring to parents' smoking status. So I think we need to get much better at asking parents and recording from them exactly what the smoking status is at the time of delivery. That's something that's poorly recorded. I think as professionals, nurses and doctors, we've not traditionally been very good at it, so we can certainly improve there. And coming back to the challenges for parents, you've already mentioned what a stressful time it is for them. Some of our prior work we've done with some of the parents have told us that it's, for the vast majority, it's the most stressful experience of their life. And that's not surprising, seeing as the babies often come very unexpectedly. They're often very sick, often their life may be in danger. There's a lot of uncertainty. Jobs difficult as well. Often the father can't be there with the mother for financial reasons. It's just a really stressful time for them. So I think that's part of the reason there's been this big reluctance on the part of medics and nurses to actually ask parents about their smoking habits, and let's still try to change those habits.
Mm-hmm. Thank you. And so just finally, what do you think from your perspective as a consultant, what do you think is needed so that we can support parents to stay smoke free?
Yeah, so it's been great to be involved with you in this in your project, Caitlin, because what I've learned is, and what we've heard from parents, that they've actually told us they want and expect to get asked about smoking. And if we don't ask them about the smoking and encourage them to try and stop smoking or prevent relapse, then who will? So there's a really important opportunity there for the healthcare professionals, not just to help the parents, but to fundamentally help our prime patients, which is the tiny babies themselves, and make a healthier life for them when they go home.
Thank you so much, Paul. I wish we had more time to talk more, but it's really important that we've heard from you. So thank you so much for joining today. Really appreciate that.
Thank you very much.
Yes, and from me too. Thanks so much, Paul. Really great to hear your insights from the ground. Now, as I mentioned right at the beginning, but those who weren't able to join then might have missed, unfortunately, our NICU nurse perspective from Amy Nichols, we're not able to share today. Unfortunately, Amy has COVID, so she is very legitimately laid up. So what we will move straight on to is, I suspect what you may all be here for really, is an outline of the Love My Lungs intervention and package and how it can be used by neonatal units and other professionals. So Caitlin, I'm going to hand back to you to take us through the package and show everybody what it involves.
Thank you so much, Caroline. So I hopefully you can all see my screen okay. If you just say yes, someone please, so I know.
Yes.
Thank you. I'd hate to carry on and find that you weren't seeing what I'm seeing. So we've heard different perspectives, which are really important on how important the problem is of tobacco smoking for families during the NICU stay. So I'm really delighted to be able to present to you the work that we've done to try and address this problem and offer NICUs a package of support for families. So the Love My Lungs intervention is a smoke-free home intervention. This is really important because it is targeted at a smoke-free home environment, which we hope removes some of the stigma around targeting parents around quitting smoking specifically. This is about a whole smoke-free home approach. And it is a whole unit approach, so we're suggesting that the package of support is adopted by NICUs in its entirety. I just really obviously want to acknowledge the brilliant work of the whole team that has gone into developing this intervention, particularly the neonatal units in Norwich and Leicester, where we did most of the primary data collection. Also the excellent researchers working on the project, our research nurses, Amy and Marie in Leicester, and also the academics and independent advisors who have been so fantastic throughout the project. So as I said, Love My Lungs is a whole unit approach. This is about NICUs being very clearly badged as smoke-free, but giving parents the support, education and advice that they need to achieve that aim. So the package really has three parts according to parents' specific situation. First of all, advice, guidance and support to create a smoke-free home environment. And part of that might be supporting parents to stop smoking where they're continuing to smoke tobacco, and also supporting parents to stay stopped from smoking in the long term, so help to avoid going back to smoking or relapsing to smoking. And the package includes, really importantly, training for NICU staff to give them the tools to be able to offer this support. I'm not going to go through this. This is just to show that the intervention is derived from theory and according to a logic model. So there are particular determinants of smoking behaviour that we target through the intervention with the aim of achieving the outcome of smoke-free home environments for our most vulnerable infants. So the training for NICU staff is really based on the very brief advice approach that some of you may be familiar with. And this approach really has been developed to enable healthcare professionals across many settings to be able to address smoking behaviour really quickly in less than a minute, understanding that for many healthcare professionals, smoking cessation is not a core part of their role. but giving them the tools to be able to address this, as obviously care for the vulnerable infant is the core part of the role for NICU staff. So the very brief advice approach has 3 elements, the 3 A's. The first element is asking about smoking status. So this helps us to identify babies most at risk of tobacco smoke exposure. This might be done through perhaps a parental questionnaire to identify parents where smoking in the home is an issue, or just asking parents directly about their smoking behaviour. Really importantly, part of this approach is that we don't ask parents if they want to quit smoking. That can engage you in a very difficult conversation. And where do you go if a parent says no, they don't want to quit? What we know is that all parents really need to quit for their own health and for the health of their infants. So we just simply ask them about their smoking behaviour and then move straight on to advising them firstly about a simple statement about the risk of tobacco smoke to their baby's health, and then advising on the best way to maintain a smoke-free environment. So this might be something like saying the best way for you to stop smoking would be to use some nicotine replacement therapy and engage with the support that we're able to offer you through our website, which we can share with you now. Then the final part of the brief advice is acting on that advice. That's offering parents support there and then. It might be offering parents nicotine replacement therapy, and also offering parents the educational support via the website. So showing parents the link to that website there and then on the unit that they can look at on their mobile phone. A key part of the practitioner training is our e-learning module that we have developed with expertise and input from a whole range of stakeholders. This is just a quick screenshot of it. This is the desktop view, but it is also really easy to access for NICU staff on a mobile phone. So it sort of has an app-based interface to enable that to be very accessible. It's a very short training, probably taking 10 minutes or so, really simple and engaging, so that hopefully we can get as much coverage for the training as possible. The next aspect of the advice, the ACT part of the very brief advice is offering direct support on the unit for dealing with nicotine cravings for parents that are trying to stop smoking. So this is enabling units to be able to prescribe nicotine replacement therapy to parents during the NICU stay. And within a research study, what we also suggest is that we offer parents the opportunity to use an e-cigarette by providing e-cigarette starter kits if parents choose that method of switching away from harmful tobacco use. Outside of a research study, of course, as NICU staff, we can direct parents to and give advice on e-cigarettes, because most hospital shops actually stock their own supply of e-cigarettes these days. And we know that the policy is much more supportive of smoking cessation where parents choose to use an e-cigarette as a way of supporting their quit attempts. Here's some screenshots of the parent aspect of the intervention. So one thing that we've developed is an app-based website. So we encourage NICU staff to direct parents to the website. We've tried to design it to be really supportive and engaging. It's designed to be viewed on a mobile phone so that parents can look at the resources during the time of the NICU admission. A key aspect of that is the virtual reality style videos we have developed. These have been really important to the intervention. They have been filmed from the baby's perspective, because parents told us that the health messages are most powerful when coming from the baby perspective, and really designed to show how tobacco smoke particles can be passed on to very vulnerable premature babies. There's a series of 4 videos, all very brief, and they cover the baby's progression through the NICU admission and then the transfer home. So the website also includes a quiz, an interactive quiz, which is really designed to give health information, but in a much more engaging way than simply reading old-style educational leaflets, and also some downloadable resources for parents as well. So I'll just finish off now by talking to you a little bit about where we are and the next steps with the intervention. So obviously I'm delighted to be kind of showcasing the intervention at the webinar today. We are going to be moving on to submit for a major national trial of the intervention to properly evaluate its effectiveness at achieving smoke-free homes. So we'll be optimising the intervention, which is really almost there. Continuing to engage with patients and members of the public to get feedback on the final stages of development. We've already been having conversations with some units who are really keen to be involved, but we'll be talking to other neonatal units who might be keen to be involved as part of the evaluation. And then hopefully, funding dependent, of course, we'll be moving on to fully evaluate the intervention at the end of this year or moving into next year, depending on the funding timeline. So it is going to be quite a complicated trial design, but really importantly, for an implementation trial, we will be looking at rolling out the intervention to units keen to take part and evaluating the process as we implement it, so that we can, as quickly as possible, make sure that units and ultimately parents and babies can benefit from the support that we're able to offer through the intervention. So that's it from me. Thank you so much for listening. I'll hand back to you, Caroline, and really happy to answer any questions.
Thank you so much, Caitlin. Brilliant to see. Lots of support in the chat for the resource overall. The video at the end looked incredible. That virtual reality approach looked amazing. And I think my overall observation in the chat, lots of appetite for this work, which is fantastic. So thank you for sharing that timeline at the end. I wonder if we might also ask Paul and Hannah back in to turn their mics and cameras back on. There has been a lot going on in the chat, so let's see what we can get through in the next 10 minutes. I think first off, lots of thanks to all the speakers, and particularly lots of thanks in the chat to Hannah and to Steve for sharing their stories, and congratulations to both of you for stopping smoking. That's really incredible success story, so thank you for that. There's been lots of examples of good practice and offers of support and emails pinging back and forth in the chat, so really delighted that that's being used as a great kind of networking and linking up opportunity. Please keep working on that. And there are some practical questions about the intervention that I'll come back to right at the end, I think. But I think two really clear themes that I wanted to pick up. Firstly, lots of support in the chat around a support for the really non-judgmental and non-stigmatizing approach to engaging with parents that is clearly integral to the intervention. So I think the kind of question emerging through that was, have you encountered any barriers or resistance amongst neonatal staff to starting the intervention or starting those conversations? And if so, how have you overcome perhaps staff fears on a neonatal unit about having this conversation with parents while their babies are on the unit? And that may be, I might start with Paul on that one, actually.
Thanks, Caroline. I honestly think this is probably the biggest barrier for staff, actually, that we worry a very vulnerable time of the parents' lives as well as for the baby. We're going to upset them, antagonize them. From the moment of birth, and indeed before birth, we're trying to build a very special relationship with these parents who we know have a very long and difficult road ahead. So we're always aware of the stress that they go through, and we're aware that we don't want to add to that stress in any way. Indeed, we're there to try and ameliorate it. So we don't want to put guilt on them, and I think that's held us back from actually asking them directly about smoking, because we don't want to sound accusatory or make them feel guilty. So we need those tools that will help us speak to them sensitively, but also, as I said before, they want us to speak to them. So we need to know how to do it in a gentle, kind, supportive way, knowing that it's going to be best for their babies and for them.
Okay, thank you. And Caitlin, anything from your research? And obviously you spoke to neonatal staff as part of the research development. Anything you would add to that?
Completely mirror really what Paul has said from his experience in the research we undertook with the focus groups with healthcare professionals. The key barrier was concern about upsetting, stigmatizing parents. It's why we particularly took this smoke-free homes approach, so that it could be a universal intervention, appropriate to all, not just targeting those people who were continuing to smoke. But also thinking about the healthcare professional training, the very brief advice approach. really is completely non-judgmental, which is why we don't ask whether parents want to quit. We just find out about the smoking status, we give them the information and the advice, and we offer the support. So there's absolutely no judgment about what parents want or what we think they ought to be doing at all.
Mm-hmm. Just one question's popped in, which I think is an interesting addition. Do you have any observations on how you might apply this intervention with staff on the unit who smoke? Is that something that's come up in your research?
I think that's a really, really important question, and it didn't come up hugely in the research, to be honest, but looking at the evidence around tobacco smoke particles, the evidence I talked about of those particles being in the NICU, someone did say to me recently, you know, how do you know that those particles aren't brought in by staff? It's a really important point. We know in other settings that healthcare professionals who smoke can be a major barrier to supporting patients, for example, the evidence from mental health settings. But what we found through other trials is that actually implementing an intervention can be really positive for changing the behaviour of staff as well as patients. For example, we're running a trial at the moment with the homeless population, supporting them to quit smoking, and we've found that many of the volunteers in homeless centres have managed to stop themselves. So there's a really positive benefit from that perspective.
Okay, really interesting. Thank you. So the other strong theme I think that's come through, and I know we've got a real kind of mix of different health professionals in the virtual room today, is around how you can really join up across the perinatal pathway. We obviously know a lot of work goes on in maternity services around smoking cessation, particularly for mums during pregnancy. So there's definitely a theme around how can neonatal units link up with their maternity teams to give consistent information. How can they learn from maternity successes, but also, I guess, learn from what's not working during the pregnancy pathway? And I wonder if I might start with a question to Hannah of, were you offered any smoking cessation support during your pregnancy, and what would have been more useful for you during that period, perhaps to help you stop during the pregnancy?
Thank you. I wasn't offered any help from the from the attendees, from the nurses, from anyone. The only help I got was from family. Yeah. So, and the what? The points that parents that Caitlin talked to gave, I think those would have really helped me at the time. So
okay, thank you. And Caitlin, have you done any work? I know obviously this research focused particularly on the neonatal unit, but to understand how those links might be drawn better. I feel like there's a great appetite in the chat for these materials to potentially be available for maternity services, and someone pointed out actually other postnatal services, not just babies who are admitted to neonatal care, but babies who go home healthy at term, but whose parents may still smoke or may have smoke in their homes.
We do have a linked programme of research actually looking at relapse prevention for term babies, so working with health visiting services. We have an active trial running at the moment, testing an intervention particularly around supporting mums to stay smoke-free. There's really interesting barriers and you know, lots of work to be done around integrating with the maternity care pathway. We know that there is, you know, quite a lump of money coming through the long-term plan to supporting smoking cessation throughout the maternity pathway. My understanding, which is, you know, I'm not an expert in this at all, but is that the NICU is sort of a slightly separate to the rest of the maternity pathway. So I'm not sure that the support through the long-term plan that reaches the NICUs, which is, you know, a key gap. Primarily one of the reasons why we felt that a sort of a separate approach, a targeted intervention was needed for NICUs. But definitely in terms of thinking about implementing this in the future, we need to make sure that it is kind of part of the maternity care pathway and links into the smoking cessation support, which is going to be increasing for women during pregnancy. It's really sad to hear that Hannah was not offered support through her pregnancy, and unfortunately that's quite a common story, I think, but we hope that will be changing in the future.
Okay, thank you. And Paul, any observations from your perspective on the ground of how the teams in the unit might work better or differently with the maternity teams in your area to join this up?
Well, I think we work very well with them regarding trying to establish and encourage breastfeeding, and rates have gone up over recent years. And we've got better and better at recognising the real importance of that early contact between mothers and fathers and their babies. So even from the word go now, we're trying to get the babies with the mothers to cuddle them before they come to the neonatal unit. And I think smoking's the third big issue, the third way that parents can have a big direct influence on the health of their babies. So I think we do need to work more collaboratively, and I think there is a lot of work to be done there. And in the work going forward, we will link up better with them.
Okay, great, thank you. So I've got 1 minute left, so a couple of practical questions and wrap up. For those who missed it at the beginning, the link to the recording of the webinar and the slides that Caitlin shared at the beginning will be available on the Action for Smoking and Health website after the event, and I believe will be emailed to everyone who's attended. So yes, you will get all of that. Caitlin, I think you've answered the question of when the real appetite for this intervention, about when's it ready. I think final version towards the end of this year, beginning of next calendar year, I think I'm right in saying. 3 practical questions, which are probably for Caitlin. Is the family's website available in other languages? Can you signpost to the evidence on third-hand smoke? And this might be a big one, who funds the nicotine replacement, either in your trial or in your recommendations? So brief answers on that if you can.
So the evidence on third-hand smoking we've included in some of the resources within the intervention, which is available to families and healthcare professionals, but I can certainly share some references to anyone interested. The funding of nicotine replacement therapy is a very important question. It's why we're really keen to apply for a big evaluation trial. Obviously, within a trial that would be funded as part of the study by the National Institute for Health Research, we hope. Outside of a trial, it's around commissioning of the CCGs, which we would be strongly advocating and petitioning for. But the best way to get it implemented in the first place is to try and get the funding for the evaluation to show the evidence for effectiveness. And then the first question I've forgotten.
Is the family's information available in other languages?
Really important question. Again, we hope within a research trial we would have the funding to offer translation. The great thing about having an app-based website is that it's extremely accessible, so can be used with a reader which can translate into other languages. The very brief advice part of the intervention, we would encourage sites to use translators as they would for the delivery of clinical care. So really important, yeah, because we wouldn't want to exclude non-English speakers.
Absolutely, brilliant. Well, all it remains for me to say, and echoing lots of comments in the chat, thank you so much to Caitlin, to Paul and to Hannah, and indeed to Steve for fantastic presentations and sharing the research, the intervention. There's clearly huge energy and enthusiasm for the intervention when it's finally launched. Thank you to everyone for contributing so many questions in chat and sharing lots of expertise and insights amongst you in the chat as well. And do look out for the recording and the slides links being emailed to you in the next few days, I would imagine, and up on the Action for Smoking and Health website. And thanks to Action for Smoking and Health and the Smoking and Pregnancy Challenge Group for hosting the webinar and for administering it so expertly. So thank you to everyone. I hope you all have a lovely rest of the day.
And thank you to you, Caroline and Bliss.